Hello everyone, welcome back to another session of Dentistry and more. Today we are going to discuss the previous year question paper that has comes under the topics Principles of Tooth Preparation, Isolation of Operating Field and Infection Control. So now I am moving to the first topic, that is Principles of Tooth Preparation. Probably there will be long essays, short essays as well as short note can be asked from this chapter. And the long essays include what are the principles of cavity preparation and define each one, describe how they are achieved in class 2 amalgam cavity preparation. And the short essays include define resistance foam, explain the resistant features of class 2 amalgam and inlay cavity preparations. Define resistance foam, what are the features given to class 2 amalgam cavity preparation to obtain proper resistance foam. Third one is define retention foam, describe establishing primary and secondary retention foams for class 2 cavity for silver amalgam. And the short notes includes, first one is class 5 cavity, next establishing resistance foam while preparing tooth for restoration. Third one is principles of carving. Fourth, retention and resistance foam for class 5 cavities. 5, reverse curve in tooth preparation. 6, secondary retentive features of amalgam cavity preparation. 7, significance of contacts and contours in restorative dentistry. And last one is tunnel preparation. So we are moving to the first question, that is principles of tooth preparation. And this cavity preparation or tooth preparation, it is defined as the mechanical alteration of a defective, injured or diseased tooth in order to best receive a restorative material that will re-establish a healthy state for the tooth, including aesthetic correction when indicated along with normal form and function. And the principles includes both initial cavity preparation stages and also final cavity preparation stages. So the initial cavity preparation stages include outline foam and initial depth, primary resistance foam, primary retention foam and convenience foam. And the final cavity preparation stages includes removal of any remaining enamel pit or fissure, infected dentine or defective old restorative material, pulp protection if indicated, secondary retention and resistance foam, and final finishing the external walls of the preparation. This includes the preparation of the tooth, principles of the tooth preparation. Now we are moving to each points, that is first one is outline foam and initial depth. All the definitions of the outline foam and initial depth, primary resistance foam, primary retention foam and convenience foam is given in the slide, so you can mark it. Now we are moving to the next one, that is final stages. That's the removal of any remaining enamel pit or fissures. This elimination of these that is left in the tooth after initial tooth preparation. Next one is pulp protection after the secondary retention and resistance foam. And last one is finishing the external walls of the preparation. This is also the point, so you can note this. Now we are moving to the short essays, that is resistance foam. It's defined as the shape and placement of the cavity walls that best enables both the restoration and tooth to withstand without fracture the masticatory forces delivered principally along the long axis of the tooth. And this is the definition. And next one is principles. So principles, you should note the following, that is use the box shape with relatively flat floors. So this will help to resist the occluding forces. And next one is resist the extension of the external walls. And next principle is provide slight rounding of the line angles. Should mention these points that will reduce stress concentration in the tooth structure. And in case of extensive tooth preparation, include enough of the weakened tooth within the restoration. So this will prevent or resist the tooth fracture by obliquely directed forces and provide enough thickness of the restorative material. So these points should be marked. And now we are moving to the features, that is first one is relatively flat floor, box shape. After that including all weakened tooth structures. And next one is preservation of the cusp and marginal ridges. Next one is rounded internal line angles. Next is adequate thickness of the restorative material, and the last one is reduction of the cusp for capping when indicated. So in the picture you can see all the features of retention. That is, there is a box shape with a flat floor box shape, and after that rounded internal line angles. All the features you can see in this figure, so you must note this figure. And next we are moving to the question, that is difference in cavity preparation for silver amalgam and class 2 cast gold inlay. So if a difference comes like that, you can make in a tabular column and to mark the differences, like the outline form is narrow in case of silver amalgam, whereas in case of class 2 the outline form is wide, and the cavity width is 1/4 of the intercuspal distance in case of silver amalgam, and in gold inlay it is 1/3 of the intercuspal distance. So you can give 7 or 8 differences between the silver amalgam and class 2 cast gold inlay. Now we are moving to the next question, that is resistance and retention features for silver amalgam. It include both primary resistance form and retention form, and also secondary resistance and retention form. In case of primary resistance form should have a relatively flat pulpal and gingival floors, that is perpendicular to the long axis of the tooth, should maintain a minimal width of the cavity so that strong cusp ridges area remain with enough dentine support, and keeping the outline form only in areas of minimal occlusal contact, and there is slight rounding of the internal line angles that we have mentioned in the early slides, and it should provide enough depth of the cavity preparation so as to allow adequate bulk of the amalgam. Next one is primary retention form, and you should note the 2 points, that is occlusal convergence of the facial and lingual walls both in the occlusal step and in the proximal box area, and next one is dovetail design of the occlusal step. And the secondary resistance and retention form includes resisting the extensions of external walls that we have mentioned earlier, and the rounding of the axiopulpal line angle by using the instrument, that is GMT, gingival marginal trim. This will increase the bulk of the restorative material and also reduces the stress concentration. And the next question was tunnel restoration. This tunnel restorations, it's mainly used for restoring the small proximal caries by using glass ionomer cements, mainly in case of deciduous as well as the permanent teeth. So it is a conservative alternative for class 2 cavity preparation in case of primary molars also. So the clinical technique include, first one is rubber dam isolation. The tooth is isolated with the rubber dam. After that, from the occlusal aspect, the access is gained by using number 2 round burr, but in a high speed handpiece. After that, the preparation is started and the tunnel is prepared diagonally under the marginal ridge into the proximal caries lesion, and this caries dentin, it is removed by using number 2 round burr, but in a slow speed handpiece. Since the access is limited, by using any magnifying loops, it's easy for more access, and the proximal enamel is either preserved or it is removed depending upon its status. And after that, during the restoration, we are using a second matrix band. And by secured by using a wooden wedge. After that, the ceramic ionomer is originally used, but presently the resin modified glass ionomers are also used. So the material is mixed and it is syringed into the prepared cavity and is contoured and protected after setting, and after 1 to 2 weeks, the occlusal surface, it is filled with the composite resin as they have more wear resistant. So this comes under the tunnel restoration, and the main advantages and disadvantages include, some of the advantages, that is marginal ridge is preserved and the perimeter of the restoration is reduced, minimizing micro leakage. The adjacent tooth is protected, somewhat like that. And the disadvantages, there will be poor visibility and the marginal ridge may be undermined, some like that. And this shows the tunnel restoration. You can see the proximal caries here, and by using a number 2 round burr with a hand high speed, cavity is prepared from the occlusal surface, and here used is metal matrix band is used, and by using glass ionomous cement it is filled the proximal caries, and after 1 to 2 weeks the occlusal surface is filled with the composite resins. So you can mark the figure. Next question was reverse curve. So this reverse curve, it is an S-shaped curve that is given to the proximal walls by curving them inward towards the contact area. So there are two types of teeth. Some of the teeth have broad contacts, whereas the other teeth have less contacts. So in case of teeth with broad contacts, if a minimal flare is given in the proximal aspect, it would result in location of the proximal walls within the contact area. On the other hand, if excessive flare is given, the proximal walls will clear the contact area but will terminate past the axial angle of the tooth through the cusp. This would result in unnecessary loss of the tooth structure and the fracture of the amalgam at the proximal corners. So in such cases, a reverse curve or S-shaped curve is given, and this helps in minimal clearance of the contact area, thus establishing a 90-degree cavo surface angle. So this helps in enhancing the resistance form of the tooth and also the amalgam. This shows the figure of the reverse curve. That is, you can see the first figure is a minimal flare. So there is inadequate proximal preparation, and if there is excessive flaring, there is excessive proximal flaring. So excess tooth structure will be lost, inadequate tooth structure. So a reverse curve or an S-shaped curve is given, that you can see here. S-shaped curve is given so as to obtain more resistance and retention. This is a figure of the reverse curve. Now we are moving to the next question, that is class 5 cavity. This class 5 cavity, it involves the cavity preparation on the incisal edge of the anterior teeth and or the occlusal cusp height of the posterior teeth. And the initial cavity preparation, there is initial cavity preparation and also final cavity preparation. And the initial cavity preparation, the outline form is based on the location and size of the caries, and it resembles like the shape of a bean or a kidney. The cavity preparation is using tapered Fisher burr. So the initial depth is 0.5 mm within the DEJ. After that, following this, the preparation is extended to include the entire caries defect. And in case, you can see the care should be taken to ensure that all the external walls are perpendicular to the external tooth surface and thereby parallel to the enamel rods, that will make the wall divergent. And the preparation must extend incisally, gingivally, mesially and also distally till the cavo surface margins. And in case of final cavity preparation, any remaining caries dentin is there, it is removed by using number 2 or number 4 round burr. And any old restoration is present, it may be retained if the tooth is asymptomatic, and if there is any further retention is provided, so retention groove is also given. So here you can see retention grooves are given, and in large class 5 cavities, retention curves can also be given to prepare at the 4-point angles. Finally, the preparation is cleansed with the air water spray. So you can see the figure, that is cavity preparation in the incisal aspect. and it should include both the mesial as well as distal, gingival and axial sides. So you can see the figure. Now we are moving to the next question, that is principles of carving. Using the adjust enamel as a guide, carve gently from the tooth surface to the enamel surface. So if the principles is asked, you must give in this order itself. So must carve gently from the tooth surface to the amalgam surface, and it should the carver must rest on the adjacent enamel and be pulled in the direction parallel to the margin of the preparation. Take care to avoid over carving, as this can make grooves deep, favoring plaque retention, and at the same time under carving must also be avoided. And in case of class 2 restoration, start the carving while matrix band is still in place, and at first begin by shaping the occlusal embrasure of the marginal ridge by removing the excess amalgam, and this is done by using a carver or explorer. Next one is create a triangular fossa and creating well defined marginal ridges. The remaining carving can be completed after removal of the wedge and matrix. After the removal of the matrix, Hollenbach carver is used to remove the amalgam flash from the interproximal areas, and leaving any excess interproximal can irritate in periodontium that leads to periodontal diseases. So you must notice the principles of carving. Now we are moving to the next question, that is significance of contact and contours in restorative dentistry. And the role of contact probably include this located contact area allows normal healthy interdental papilla to fill the interproximal spaces, and the proximal contact of all the teeth in the same dental arch and their interdigitation through occlusal contact with the opposing teeth stabilizes and maintains the integrity of the dental arches. It prevents the food from packing in between the teeth and thereby preventing the impingement of the gingival tissue. And the next slide shows the role of the contours. So you can look at the slide. Next one is hazards of faulty contacts. If it is too narrow contact, that is buccolingually or occlusogingivally, main one is foot lodgement may occur vertically or horizontally on all areas, and if the contact place is too gingivally, it may leads to it may increases the depth of the occlusal embrasure impingement on the interdental cord, and there is open contact area, so that leads to foot impaction, leads to the periodontal and caries problems. In case of the contact is placed too occlusally, that may leads to flatten the marginal ridges at the expense of occlusal embrasures, and if the contact is placed too buccally or lingually, it will result in flattened restoration at the expense of buccal or lingual proximal walls. This concludes the first section, that is principles of cavity preparation. It's a very important chapter. Be thorough with this chapter. And next we are moving to the next section, that is isolation of the operating field. And the important questions comes from this chapter are: first one is enumerate methods of gingival retraction, and describe the steps involved in placement of retraction coat, enumerate the methods of moisture control, describe briefly the materials and devices used for rubber dam application, enumerate various parts of rubber dam kit, describe the procedure for placement of the rubber dam, and the same question repeats. And after that, enumerate gingival retraction technique, add a note on retraction code. So the common question is gingival retraction methods and note on retraction code placement. And the short note is also different methods for gingival tissue management. We are moving to the first question, that is gingival retraction. It is defined as the deflection of the marginal gingiva away from the tooth. It is also called as gingival displacement or tissue dilation. So the methods of gingival retraction includes: First one is mechanical, and next one is mechanical chemical, next chemical, and last one is surgical. So we are moving to the each points, that is first one is mechanical. Mechanical, it means physically it displaces the gingiva, and the types includes copper band, rubber dam, cotton threads, and also magic foam. And next one is the mechanical chemical. That one is the retraction code is used for mechanically separating the tissue from a prepared margin, and then it is impregnated with a chemical for astringent action or hemostasis as impressions are made. So there is both mechanical as well as chemical action, and the major chemicals used are, first one is ferric sulfate, aluminum chloride, and racemic epinephrine can also be used, but it is not commonly used since it causes tachycardia. And next one is chemical. It mainly consists of aluminum chloride containing paste which is injected into the sulcus prior to impression making, and the paste is left in the sulcus for 3 to 4 minutes to achieve the desired retraction. So aluminum chloride paste, and it is injected into the sulcus and it is left for 3 to 4 minutes. And the surgical includes rotary curage, electrosurgery, and soft tissue laser. Next question was displacement technique, gingival displacement technique. Usually two methods are employed, that is single cord technique and also double cord technique. In case of single cord technique, only one cord is placed in the sulcus, and as the impression is made immediately followed retraction after the removal of the cord. So the cord is removed, after that immediately the impression is taken. But in case of double cord technique, the two cords used, that is one is a thin cord and the another one is a small diameter cord and the another one is a large diameter cord, and the thin one it is packed into the sulcus and is left there during the impression, and the second cord is placed over the first and it is removed immediately prior to the impression making. So this is the difference. First one is single cord and second one is double cord technique. Single cord technique is the most commonly used method and it is very simple and efficient. So cut the appropriate length of the cord to encircle the tooth 2 inches approximately. After that it is moistened in a chemical agent that is placed in dappen dish, and it forms a U shape, and it is prepared, it is looped around the prepared tooth so that the cut ends are on the lingual side. So here you can see by using the thumb or forefinger we can grasp the cut ends from the lingual side, and after that an apical tension is given. So it is getting tucked in both the proximal as well as the labial surface, and first it is secured in the proximal area and after that in the lingual and also the facial surfaces. If there is excess it is cut off, and after 10 minutes it is moist the cord with the saline or sterile water, and it is removed slowly to avoid the bleeding, and if the bleeding persists then ferric sulfate chemical is applied to the gingiva. And this figure shows the single cord technique. First one is this cord, it is impregnated in the chemical solution. After that by using the thumb and forefinger it is grasped from the lingual surface, the cut ends, and it is apical force is given, and the proximal areas and also the lingual areas are tightened. After that the excess is cut and a small portion is left there for easy removal, that you can see here. And if the after that it is moistened and remove the cord, if still bleeding occurs then there is application of the ferric sulfate. So this includes the single cord technique, whereas the double cord technique similar to that of the single cord but is commonly used to make the impressions of multiple prepared teeth. And when the tissue health is slightly compromised with more normal bleeding. So here a small diameter is first placed into the sulcus and it is placed there till after impression making, and a second large diameter cord is placed over the first one and it is taken just before the impression making. The second cord that is soaked in the hemostatic agent of choice is placed in the sulcus above the small diameter cord, and the diameter of the second cord should be maximum diameter that can place easily into the sulcus. After 8 to 10 minutes, it is moistened, removed, and the impression is made with the first cord in place. After making the impression, a small diameter cord is also moistened and removed from the sulcus. So, in this figure, you can see this one is the small diameter cord and this one is the large diameter cord that is placed above the small diameter cord. Next one is method of fluid control. Common methods are rubber dam, cotton rolls, high vacuum suction, somewhere like that, so adopter. And now we are moving to the rubber dam equipment. First one is rubber dam material. It is made up of latex rubber and there is several thickness of the rubber dam sheet, that is thin, medium, heavy, extra heavy and special heavy. And this rubber dam sheets, they are available in light and also dark colors. So this dark colors, it will give more provide good contrast with the teeth so that it can be easily removed. And most of the procedures, the heavy thickness rubber dam is used, and also extra heavy and special heavies are used when there is need of better gingival retraction, and the thinner is used when contacts are very light. Next one is rubber dam holder or frame. It usually holds the border of the rubber dam material, thus preventing it from falling into the mouth or back against the patient face. It can be made up of both metal or plastic. The rubber dam retainers, it is the clip or retainer that fits on the neck of the tooth and it holds the rubber dam in position. It also provides gingival retraction. It can be of different sizes and shapes. And there are two types, that is both winged and also wingless. These clamps can be of two types, that is winged and also wingless, and you can see the two types, that is winged and also wingless in the figure. And this clamps can be of butterfly type clamp, that is usually for anterior teeth, universal premolar clamp for premolar teeth, mandibular molar clamp and also maxillary molar clamp. Next one is rubber dam punch, that is an instrument which is having a rotating metal disc with 6 holes, that is of different sizes, and this punch is used to cut the hole on the rubber dam sheet. And the most of the rubber dam punches, they have 5 or 6 holes, that is smaller holes, that is for incisors, canines and premolars, larger holes for molars and largest one for posterior most anchor teeth, and this small for incisors, canines and also for premolars, whereas large for molars and posterior most for largest hole. Next one is rubber dam template. So it is a inked rubber stamp that helps in marking dots on the rubber according to average position of the teeth. Next one is rubber dam clamp forceps. It is an instrument used for placing, adjusting and removing the clamp. Next one is napkin. It's a soft, absorbent, disposable napkin that is placed in between the dam and the patient's skin. So it will reduces the allergic reaction in case of sensitive patients. Rubber dam lubricant, it is a water-based gel or other lubricant like shaving cream or liquid soap. So it is used to allow easy gliding of the sheet over the teeth and through the proximal contacts. Next one is other retainers. Instead of the clamp, sometimes other methods are also used to retain the rubber dam. It may be floss or tape, elastic cord, something like that, and a modeling compound. Low fusing modeling compound is used. And next question is rubber dam application technique. So in prior to the application of the rubber dam, there is some preliminary procedures are there. That is, first you must check the patient's mouth if there is any calculus or any stains are present. So if that is present, first perform the oral prophylaxis. After that, if there is any sharp edges, then polish the sharp edges. And in case of any tight contact or rough contact areas, you must polish those areas also. So for the easy passage of the rubber dam sheet. And these preliminary procedures must be performed first. And the gingival area is anesthetized so as to prevent the pain. After that, the operating field is rinsed and dried. There is single tooth isolation and also multiple tooth isolations are there. In case of single tooth isolation, this is done for following situations like pit and fissures, class 1 restoration, class 5 restoration, and endodontic procedures. In case of posterior teeth, there is a necessary of the rubber dam retention, while in case there is other alternatives can be used. So the clamp is applied in 3 techniques, that is, the clamp is placed prior to the rubber dam, and the clamp and the rubber dam are placed together, and the clamp is placed after the rubber dam. So first one is clamp placement prior to the rubber dam. As the sentence mentioned, the clamp is placed before the rubber dam. So first one is appropriate winged clamp is selected and it is trial fit. After that, the floss is tied to the clamp for the safety against the aspiration and injection. And for easy placement of the rubber dam over the clamp, a large hole is punched, and the stretch the rubber dam first over the bow. After that, next stretch it's over the buccal jaw of the clamp, and now allow it to settle against the gum margins beneath the jaw, and similarly position it beneath the lingual jaw of the clamp, and check if the dam has passed through both the contacts, and then apply the napkin and the frame. So you can here see the pictures. First one is the dam is stretched over the bow of the clamp. So the clamp is already placed there, and the rubber dam, it is positioned beneath the jaw of the clamp. And last one is the frame and the napkin is placed in position. And the advantages and disadvantages includes it's quick and easy technique, it's minimal trauma to the gingiva, and good vision of the clamp and the tooth during placement. Now the clamp and the rubber dam, they are placed together. So here winged clamps are used. So suitable winged clamp is selected, and also a large hole is punched in the dam and it is stretched over the wings of the clamp, and the bow, it is positioned first on the distal aspect of the tooth. After that, in combination, it is carried to the mouth by means of a forceps. Then the rubber dam, it is moved over the wings. After that, it is positioned around the cervical region of the tooth, and finally frame and a napkin is applied. This figure shows that is initially both the clamp and the rubber dam is placed. After that is placed over the prepared tooth, and finally napkins are used. And the advantages, it is useful in case of third molar regions, and some drawbacks are also there, that is limited vision during clamp placement and may traumatize the gingiva. And third one is the clamp is placed after the rubber dam. So this requires a assistant for quick application. So appropriate clamp is selected, and after that the rubber dam is taken and a correct size hole is punched. This dam, it is stretched over the crown of the tooth, and it is pulled apically so that the gingival margins are visible buccally and lingually, and the assistant then positions the clamp, and finally the frame and napkins are fitted. So also applied, it's easy to apply on the anterior teeth, but drawbacks are it's difficult access to posterior teeth and requires the aid of an assistant for easy application. This the figure shows that the rubber dam is stretched over crown of the tooth, and the next figure shows the clamp in the proper position, and the last figure rubber dam clamp that is being placed here. Next one is the rubber dam application for multiple teeth. It is commonly used in situations like bleaching or class 2 restorations or multiple restorations. And in case of few teeth requires restoration, at least one tooth on the either side of the teeth under treatment should be isolated. And the clamps, they are usually present on the tooth distal to the involved tooth. And when there is several teeth need treatment, the isolation is extended across the arch for clear access and good retention of the rubber dam. The anterior anchor tooth often does not require clamp, and wedges may be used for retention. So isolation of the anterior teeth, and this mainly involves the 6 anterior teeth, and the premolar is here as serves as an anchor teeth. So the clamps, wedges can be used. First, the rubber dam, it is secured over the anchor teeth. Next one is the remaining teeth, they is exposed to the punch holes. The rubber dam, it is inverted into the gingival sulcus, and by using flows it is tied at neck of the exposed teeth, and finally the napkin and the frame is fitted. So here you can see the isolation of the anterior teeth. The premolar is here, premolar is used as the anchor teeth, and following this anterior teeth, they are tied by using dental flows. So, and finally napkin ends in the frame are fitted. Next one is isolation of the posterior teeth. In case of that, for isolation of the posterior teeth, it must extend up to the canine or incisors of the same quadrant, or it should cross the midline. So holes are punched for the individual teeth, and the clamp is positioned over the posterior most tooth, and this will act as anchor teeth. And the remaining teeth, they are exposed through the dam, and the flows is used to pass the rubber through the tight contact. So you can see the posterior most teeth acts as an anchor, and it must extend to the canine or incisor of the same quadrant, or up to the, or it should cross the midline. After that, by using the flows, it is tied over the canine, and last we can give napkin and also frame. Next one is in case of special situation, that is for matrix placement. That is when the matrix band has to be placed, so the clamp has to be removed and is replaced by a matrix retainer and band, and the band serves as the purpose of the clamp. In case of cervical cavities, the proper retraction, a heavier rubber dam can be preferred in case of cervical cavities. Next one is removal of the rubber dam. Once the treatment is completed, the rubber dam is removed by reversing the step in the technique that is used for rubber dam placement. So, by reversing, first one is remove the wedges or flows. After that, cut the interdental dam by stretching buccally, and following this, the clamp or any retraction aids are removed, and then removing the rubber dam can be finally removed along with the frame. And in case of any tight contact, carefully remove the rubber dam and check for remnants of rubber pieces in the interproximal areas. And this figure shows the removal of the rubber dam. Aids for the leaking dam. Sometimes it may not be possible to achieve a moisture proof seal with the rubber dam. So it is most often prevented by the following means. That is, first one is proper preparation of the tooth and the operating site. And next one is correctly positioning the hole in the rubber dam and selecting the right clamp. And third one is inversion of the dam around the tooth and the final sealing with the dental floss. So this concludes the next section, that is isolation of the operating field. Now we are moving to the next topic, that is infection control, and it's a very easy chapter. Solely probably one question can be asked, that is main question will be autoclave and mouth mask, or enumerate the methods of infection control procedures in operative dentistry, somewhat like that. We are moving to the first question, that is autoclave. And in case of autoclave, you must mention the principles of autoclave, that is its steam above the 100 degrees Celsius, and somewhat like that. You can read the slide and you can write the important points. After that, the sterilization conditions, that is 121 degrees Celsius temperature, 126 degrees Celsius temperature, and also 133 degree. And the advantages and disadvantages, you can mention any one or two advantages and disadvantages. Less time consuming, as it is a moist heat, it is more penetrating power. And the disadvantages, equipment is costly and there is a chance of explosion. Next one is infection control. So in case of any question asked like infection control, you must give the headings like OSHA, that's Occupational Safety and Health Act, that was passed by US Congress in 1970, and the regulations of the OSHA, that the provision for hepatitis B vaccination, and the universal precautions is, you must give the universal precautions. We must be thorough with these precautions. Careful handling of these sharp instruments, use of the device to reduce contamination risk, somewhere like that. Here, that is the precautions. Next one is disinfection of the surface and equipment of the dental office, and the surface and equipments which do not permit sterilization should be treated with disinfectant prior to seating the patient and in between patients. For example, operating light handles, chair controls, tray arms, and three-way syringe, somewhat like that. And the method to reduce the cross infection is safety glasses should be worn to protect the eyes, mask should be worn for protection against the aerosols, and gloves must be worn. And methods of sterilization mainly includes, first one is autoclaving. It is a steam pressure technique sterilization. After that, chemical vapor pressure sterilization. Dry heat mainly includes red heat, hot air oven, incineration, and ethylene oxide sterilization. And the sterilization of the handpiece and related rotary instruments by scrubbing with the disinfectant. Steam sterilization, chemical vapor pressure, cleaning with soap, wiping with alcohol, and sterilization of impressions, that washing the impression with the disinfectant solutions such as 3% phenol, ethyl alcohol, and formaldehyde. Next question was mouth masks. So here, surgical mask that covers both the nose and the mouth should be worn, should not provide complete microbiological protection, but they prevent the slatter from contaminating the face, and it should be changed regularly. And if the mask becomes wet, it should be changed between the patients or even during the patient treatment. Maximum time should not be more than, wearing the mask should not be more than 1 hour. And in order to greater protection against the splatter, a thin length plastic shield must be worn in addition to face mask. Example, 3-layered surgical mask, N95, and also diagnostics mask. So here ends the first 3 topics of the conservative dentistry question paper. Hope you all understood this section, and we will come back with another section. Thank you for hearing my words. Thank you.